I am so thrilled to be introducing our first speaker, Dr. Annie Fukushima, who is a Presidential Fellow of 2020 of the University of Utah. She is also the Assistant Professor in the Ethnic Study Division of the School of Culture and Social Transformation. She has just published a book called Migrant Crossing that deals with human trafficking across the USA, and Utah, as you know, is 8th in the nation with human trafficking. She writes about reflections about court cases from social perspectives, which is very, very exciting. And what is even more exciting is Dr. Annie Fukushima, along with Dr. Sonia Solari, were gifted with one of the 1U 4U awards that Dr. Ruth Watkins brought about for a 1U campus. And it is to develop a gender-based violence consortium that all of us are so privileged to be a part of. So we're very excited to hear about it. With that, I would like to introduce Dr. Fukushima.
So wonderful to be here. I'm going to go ahead and put into the chat some links for folks to follow along in case if that's easier for you. There's one where you can follow live, or you can go ahead and follow at your own pace if you want to bounce around in the slides. I want to thank WiHMS for having me here. Thank you so much for hosting this webinar. So for today, we are talking about the fight against gender-based violence. And just a little bit about me. I think it's important to share a little bit about some of the things that are driving my work. And so in my work, my book focuses on witnessing as a theory and practice, and how witnessing encompasses the self-witness, the account of events, the witnessing of the process of witnessing, and the witness as human and non-human. And so I do see witnessing as something that is multiple, and that we're all participating in the practice of witnessing. And so when we think about gender-based violence, many of us are witnesses, whether it's a self-witness to violence or witnessing those who are surviving and working through it in their communities. But what we know is that witnessing violence happens in multiple ways. And just to share very quickly a little bit about my own journey is that I have worked at all levels of organizations, including being a member of the board of directors for the National Coalition Against Domestic Violence. I've done citywide needs assessment on violence against women and people, where I interviewed and surveyed communities regarding domestic violence, sexual assault, and human trafficking. And I also am a legal witness in the sense that I provide testimonies to courts, both for criminal, civil, and immigration courts. And so that's just a little bit about the ways that I have participated in a practice of witnessing and also facilitated in my own research. So what is gender-based violence? We're here to think about gender-based violence. And gender-based violence is understood as a violence that results in physical, sexual, or psychological harm or suffering based on a person's gender, where coercion or arbitrary deprivations of freedom occurs in public or private life. But that definition is something that's important for a guiding way to think about it. But I wanted to also offer this way of thinking about it. And here I'm thinking with the work of Rosalinda Fregoso and Cynthia Bejarano, among other scholars who have thought through gender-based violence, in which when we think about gender-based violence, it is a violence that is shaped by power structures. And when we talk about those power structures, we can say heteropatriarchy, racism, systems of colonization, and the list goes on. And that we know that when we think about gender-based violence is that it cuts across both public and private life, implicating both the state directly or indirectly and individual perpetrators, private or state actors. And so gender-based violence is not about it just being relegated to the home, but also making the links between what happens in the home as something that is also impacting public life. It also encompasses systematic, widespread, and everyday interpersonal violence. And one thing that we know about gender-based violence is that while it does impact all of us, we all inhabit the world with our with gender performances and move around the world in our gendered bodies. But we do know that it does impact communities based on social, political, economical, and cultural inequalities. And so just to really help us think about what is gender, is that gender is a socially constructed category in which the performance of gender norms, rather than the natural biological essence, is what gives meaning to the categories of the feminine and masculine. And so when we think about, for example, what we would consider women, girls, men, boys, transgender, gender nonconforming, and the many genders that comprise our society, is that we give meaning to those categories. And we recognize that gender is complex. It is a multi-level cultural construct structured by intersecting identities. And here I'm thinking along the lines that we cannot not think about gender and also not think about race, class, and sexuality, and the list goes on. So how does gender-based violence occur? Well, gender-based violence occurs in a range of things that we recognize. And here I've provided quite the long list of many forms of violence that we see happening and that the University of Utah's Gender-Based Violence Consortium is seeking to track. It results in a range of forms of abuse that includes abduction to border violence, child abuse, human trafficking, forced marriage, to homophobia, missing and murdered Indigenous women, and Two-Spirit, right? And so the list goes on, right? When we think about gender-based violence, it is quite all-encompassing of a range of forms of violence that occurs in our communities. And for me, thinking about gender-based violence as cross-cutting across many experiences is really important, because in the work that I do on human trafficking, for example, is that what I learned is that I could not look at a case and not also make the connections that, say, for example, when somebody was being trafficked into sexual economies by a lover, that intersected with domestic violence or intimate partner violence. And I could not think about it in the context of other forms like economic deprivation and so forth. And so when we think about gender-based violence, it is quite a complex system that we're talking about of a range of violences that occur in our society. There are some data, though, that in particular here for Domestic Violence Awareness Month, I wanted to share some trends just to get us, thinking about what is really going on. And so we know that according to the National Network to End Domestic Violence, is that more than 1 in 3 women have experienced rape, physical violence, and are stalking by an intimate partner in their lifetime. That nearly 8 million women are raped, physically assaulted, and or stalked by a current or former intimate partner each year. 1 in 5 women and 1 in 71 men have experienced rape in their lifetime. And that nationwide, an average of 3 women are killed by a current or former intimate partner every day. And so we know that gender-based violence in the form of intimate partner violence, rape, sexual assault impacts our communities across the country, as well as even locally in Utah. And for local trends, you can visit the Utah Domestic Violence Coalition for information on that. We also know that there's other ways for thinking about this, is that 4 in 10 women and 4 in 10 men have experienced at least one form of coercive control by an intimate partner in their lifetime. And again, these handouts, and this is from the National Coalition Against Domestic Violence, they are framing the discussion based on what we know about women and men, and that we know that it just as equally impacts the LGBTIQ community. And so we don't want to forget that our range of gendered bodies are being impacted by domestic violence, human trafficking, and sexual assault. But it is a public health issue. It has serious reproductive, sexual, psychosocial, and public health concerns. And that we know that, that when somebody experiences gender-based violence, they are likely to experience poorer health, chronic pain, issues with memory related to trauma, and reproductive related problems that our healthcare professionals can talk more specifically about. But the numbers that I'm sharing with you all, and again, you can revisit these links and handouts, is that what we know, as my colleague Sonia Solari would show in her, iceberg of maltreatment, is that what we know is really just the tip of the iceberg. There is so much that we still do not know and have yet to come to know, because many survivors of violence do not necessarily report their abuse, do not necessarily disclose, and may enter a range of systems, including healthcare systems, never disclosing the abuse that they're going through. And that we know that marginalized communities experience a range of barriers that are oftentimes not counted. And so here, communities of color are impacted by domestic violence. And I don't want to say that only communities of color, we are all impacted by it. But it is important to understand how racial dynamics impact the way that communities are accessing resources and how those very systems perceive them. And so here, I have a quote from a study that I conducted, in which I think part of what is unique about our population is that it's the intersection of domestic violence and homelessness. And I think that's true for anybody who's providing shelter. You have to demonstrate that they're indeed homeless due to domestic violence. And that we know that communities who advocate for a range of marginalized communities that are houseless or chronically homeless are seeing a range of other issues related to health and other social implications. But we know that people that are chronically homeless or marginally housed do experience domestic violence and are definitely experiencing all kinds of stigma when they try to seek services. Here's another quote. And this is actually from a study that I'm conducting currently with my colleagues, Sharon Talboys and Sonia Solari, in which they are the leads on this particular project. And my colleagues that are working with them, including myself, are Heather Melton and graduate students, Megan Pedersen, Michelle Sieg, and Angie Eliason. So this quote is from that particular study, in which we are learning more about how domestic violence is impacted by shelter-in-place policies during pandemic. And so we're really doing a COVID study on domestic violence and trying to learn more about how our communities are responding and how survivors are surviving it too. But here, regarding the cultural context, where we're thinking about race, so the first quote was thinking about the class dynamics of homelessness. But here, when we think about race, this quote says, "I noticed that the Hispanic community, it takes them more time to reach out for help. There might not be services available, or it can be a cultural issue. They'd rather resolve the issue within the community. So it takes them more time to come forward, or maybe some language barriers." And when I've worked with communities in the Latinx community, both in Utah as well as in California, is that when we think of the Latino community, we oftentimes think of Spanish speaking. But what we know is that the Latinx community has a range of indigenous languages that they speak. And so maybe seeking out services in Spanish may be available, but their indigenous linguistic needs are not. And so they themselves are translating through another language to speak to somebody who's also translating. But there's a range of also cultural reasons why people may experience barriers. And so resources that are localized, that are culturally based in tandem with other institutions are really important. And there are local organizations. And one organization that I think of that is doing really amazing work with the Pacific Islander community is PICTAR. And they're also doing a violence prevention conference that I really hope folks check out, since they're really going to be sharing a ton of information on the cultural context of working with and supporting the Pacific Islander community, which is very complex, right? And we know that in particular the case of Utah, there is a visible presence of Tongan and Samoan Pacific Islanders, as well as Kanaka-Maoli and other Pacific Islanders. But when we think about this cultural context and dynamics that come into domestic violence, we also have to think about the complexities of gendered experiences and how people are accessing or being even denied resources. And so here, when I interviewed for a needs assessment in California, Here I interviewed a survivor advocate who said, I feel transgender people are underserved. I've had few clients or survivors that are trans and they've told me that they don't want to file a police report. They don't want to do anything because of the stigma of who they are. Or they did do a rape kit, but they didn't like how they were being treated. A lot of the transgender people know what kind of treatment they might get with the police. So they're not willing to come forward to report their abuse or to receive services from us because of stigma surrounding who they are. So I feel like that population is underserved as well as male survivors. And so we know that the trans community, even in a context where there are a range of transgender services, such as like in California, are still experiencing a range of barriers. And so we know that pandemic has impacted our responses to gender-based violence issues, and that it means then that, so I'm going to kind of move ahead because I know that I'm kind of running quick on time. And so I did have some slides where I was going to talk a little bit more about how pandemic has impacted our response, and I'm happy to save that for the question and answer. As that is something that we maybe can discuss. But one of the things I do want to appeal for is that we move towards a gender-based violence a framework because it allows us to think about the complex, and that communities do not witness and experience violence in a vacuum. And so as I framed earlier, when I was working on human trafficking, I could not delink the ways that other forms of violence from across the life course was impacting survivors. And so our systems of response are also seeing a range of abuses that affect people. And therefore we must also think that way, both in a very critical way. And so we are collectively, I'm inviting all of us to move towards the complex. And that we link powers dynamics of things like domestic violence and gender-based violence with other forms of oppression as well. And so today, in the last 5 minutes, I do want to share with you is that in the lessons from witnessing, I've worked with a range of communities who have really inspired me to really think about what does collaboration look like and what does collaboration mean. And here, I won't have time to read the quote, but you can read it on your own, in which we hear from a Hawaiian trans woman talking about how she is using every penny that she has to support her communities. And so when we think about what that then means for our own practice, and what it means that how do we then coalesce, work together to support the most marginalized in our society, it really is through coalitional work. And so that was the reason why we created the Gender-Based Violence Consortium. And my colleagues here, Drs. Leslie Halpern and Dr. Yoshimi Anzai, are both centrally a part of these efforts. And so the Gender-Based Violence Consortium brings together an interdisciplinary team of scholars representing multiple colleges across the campus at the University of Utah. We are an interprofessional collaboration, a scholarly network that embodies an academic commitment to sharing knowledge, supporting long-term collaborations through research hubs, creating programming, sharing teaching, and responding to gender-based violence. And so this is just very quickly a list of our colleagues. We really do envision ourselves as an effort that is not just for University of Utah, but for Utah, a university for Utah. And so our collaborators include WiHMS, UDVC, SVS, Nexus, Digital Matters, and a range of other informal collaborators that have been emerging as part of our consortium. And I won't have time to go into details about it because I have 2 minutes left, but some of the quick highlights we are working on is visualizing gender-based violence in Utah since the 1990s. That's one of our big projects that we're currently collecting data that will analyze a history of research, policy, services, and eventually will incorporate a history of injury. And but for April 2021, we will be piloting the data that we've collected to the public to interact with this interface so that we can continue to learn more about what it means to create discourse through visual platforms. We have folks who are doing a COVID study, as some of the quotes highlighted, as well as all of our colleagues that are in our executive board, as well as that participate in the Gender-Based Violence Consortium, are doing a range of gender-based violence related work that is super meaningful. And so some of the things that you all should keep an eye out for is that we are creating a toolkit for educators in collaboration with Fight Against Domestic Violence. That toolkit will be made available sometime by the end of this month. And that we are working with local organizations to think about a campaign efforts that move us into thinking about sexual violence and addressing it in our communities. And again, want you to calendar that April 2021, we will be soft launching our interactive platform. And I don't want you to forget that this month is DVAM 2020. And so there are wonderful events that are in the pipeline. I'll copy and paste these events for you to also click on. So if you want to join, we'll be hearing from leaders who are doing amazing work in Native communities, as well as we will hear from our healthcare experts. And so we will be seeing our colleagues, Dr. Halpern and Dr. Anzai, join us as speakers for that, as well as other folks. And so without further ado, I just want to thank you all for giving me this time, and I'm going to hand it over to my colleague.
Hey, the wonderful presentation, and I'm sure a lot of food for thought for questions. I'm going to turn this over now to my colleague, Dr. Yoshimi Anzai, to introduce our next speaker, and this will leave us a good amount of time for questions and answers. That will combine the two.
Thank you, Annie, and thank you, Leslie. My name is Yoshimi Anzai. I'm a co-director of WIM, and also I'm a professor of radiology at School of Medicine. So Annie Fukushima just provided such a broad view of gender-based violences and how their team and consortium is really engaging community and all domestic violences from the very multifaceted approach. Now I'm very pleased to introduce the next speaker, who is Dr. Marta McCrum, who is Assistant Professor of Department of Surgery, and she is the shining star of a trauma surgery team that I know. Dr. McCrum graduated from McGill University and also received Master of Public Health and Health Policy and Management from Harvard School of Public Health. And she finished the residency training of surgery in Brigham Women's Hospital, and also fellowship in trauma surgery at the University of Washington, Seattle, that I spent 15 years of my career. So, and prior to coming to University of Utah, so we had a kind of similar track record. When before Dr. McCrum joined, trauma surgery was sort of like a lot of boys club, and where I finally found a beautiful and also very strong women's surgeon and trauma team, and I'm so excited. And Dr. McCrum is leading domestic violences committee and really passionate about whole team, not just the physician, but the nurses, case manager, social worker, creating a multidisciplinary team to address this domestic violences and also gender-based violences. So without further ado, I will have that screen share to Dr. McCrum, please.
Thank you so much. It's a pleasure to be here, and thank you for that lovely introduction. I'm going to speak from the perspective of our trauma team, on behalf of our trauma team, and give you the perspective of clinical trauma services. So I'll share my screen here. And I really have three things that I want to touch on in this presentation. First is the prevalence of intimate partner violence in our trauma population. Secondly, the concept of screening trauma patients and why that's important. And finally, some primary prevention initiatives that our team is undertaking. But to give you a little bit of context, so as Dr. Anzai mentioned, I'm a trauma surgeon. I'm a board certified general surgeon who has additional training in trauma and critical care. And so this is where I meet most of my trauma patients. This isn't our trauma bay. This is a picture of another very clean and new trauma bay. But this is where our team meets most of our trauma patients. And in order to be qualified as a trauma activation where you're having, the trauma service as well as subspecialty services all assemble prior to patient arrival. You need to meet certain triage criteria, which generally means that patients who arrive and are being activated as a trauma activation are very severely injured. From here, in the trauma activation, we have emergency physicians, trauma surgeons, nurses, pharmacists, social workers, and then our colleagues from radiology, orthopedics, neurosurgery. We evaluate the patient together, and then from here, patients undergo additional workup or admission. So just to give you a sense of the clinical arena I work in, it generally starts in this environment. But a little bit of background, I'll go through this really quickly because we've gone through a lot of statistics already today, but intimate partner and sexual violence accounts for about 2 million injuries annually, and 1,300 IPSV-related homicides in the United States. And among women, it's estimated that anywhere from about 5 to 30% of all trauma admissions in women are related to intimate partner violence. So this is a big problem for the trauma population that we see clinically. And intimate partner violence is a threat to both women and men, with estimates of 3 to 14% of women affected annually and 2 to 18% of men. I'm going to share very quickly a clinical case. This was a woman I met in my first year as faculty here. There's a 32-year-old woman who was transferred to our hospital from Nevada. And the history we received was that she was assaulted. She was found unclothed and bound in the back of a truck. Her Glasgow Coma scale was 14 out of 15, meaning she was mildly confused, and she had diffuse bruising all over her body. Her social history we found out a little bit later in our evaluation, but I'll put it up front here. She was married. She had 12 and 5-year-old daughters. She was unemployed, but was a veteran, had been previously deployed in the Navy. And she had an ongoing history of intimate partner violence, which was reported by her 12-year-old daughter as an ongoing issue. She also had a number of other medical comorbidities, including a history of anxiety, substance abuse, and alcohol abuse. So this is her CT scan, and for those of you who are not clinical, this is an imaging modality that we use. The patient, you can imagine the patient lying on a table with her head away from us and her feet towards us, and we're taking slices through her like a loaf of bread. And this is a slice of her chest. And we can see her lungs here, and this is her sternum or her breastbone, and then ribs around the side. And what we see is that she has some very severe rib fractures. She has collapse of both her lungs, and then a complete disruption of her chest wall with air leaking out into her soft tissues. Really extensive air, which we call subcutaneous emphysema. But the picture here is an extremely violent force and a very, very severe injury to her thorax. She had multiple rib fractures, like I said, dissociation from her sternum. Her lungs were collapsed, and she had other fractures as well. And she was having so much problem breathing that she was intubated with a breathing tube prior to transfer to us. She had tubes in her chest to try and re-expand her lungs. And she underwent fairly urgent rib plating, and then even a muscle flap to try and recreate that chest wall. And so you can see the degree of devastating injury that this woman sustained. So to come back to sort of our overview, we think of our patients in kind of a continuum. On the left side of your screen, we have people in the community that have certain behaviors, risk factors, and interactions. We may have patients or individuals who enter into certain relationships in which they experience intimate partner violence, and that may be a recurring event, or there may be some singular event that brings them to a hospital, and then from there they are discharged, most often to like a non-rehab, a home environment of some sort. But we'll start here because this is where I meet most of my patients, is at the hospital. This group from the University of Arizona, led by Bilal Joseph, wanted to know what the prevalence was of, they used the term domestic violence because they were capturing kind of a larger population among trauma patients that we see as clinicians. And they used the National Trauma Data Bank, which is a fairly rich source of trauma quality improvement data over a 6-year period. And they looked at trauma patients who experienced domestic violence related admissions. So that was their indication for being admitted to the hospital, and stratified these patients by age. They found, if you look at this, this is the red box here is their total study population. They found that the population of patients admitted with domestic violence related injuries was about half male, half female. There was an overrepresentation of minority communities and minority patients. And then about half of patients were admitted with head injuries and about a third with extremity fractures. Looking at the adult and elderly population, just because we're going to concentrate on that in this talk, we again see an overrepresentation of Black and Hispanic patients, and then a high proportion of head injuries and extremity fractures. And even though the gender spread or the sex spread is slightly different, we still see about 40% of patients are male, underlying the fact that this is an issue that affects both males and females. Over time trend analysis, they saw an increase in the incidence over the 7-year period, and once again, that applied to both males and females in their study. But overall, they found that they were surprised by the incident was actually fairly low when you compare it to other studies, 5.7 cases per 1,000 trauma admissions or trauma center discharges. And that really raised concern for lack of proper screening or reporting of domestic violence in our trauma patients. It's not that it's not there, it's that we're not identifying it well. Their limitations were obviously that they could only identify cases that were diagnosed and coded. And so it brings into question about, if it's not reported or coded in our medical charts or medical records, it's not going to be identified. And that's why we see this large discrepancy between ED-based studies where we have 22 to 54% of all ED patients screening positive versus 0.5% of these trauma patients that were admitted. And then there's also a lot of variability in definitions and reporting systems in the medical literature. And so from this study, we saw that there's a lot of work that needs to be done. And so the next question is, well, what do we do? And if we move one step forward, we think about screening. And how do we identify patients who are experiencing intimate partner violence in the community? Trauma systems, and the trauma system in the hospital is a difficult place to learn how to screen patients. This is what a normal trauma resuscitation looks like. It is not a private room most of the time. Even a low-level trauma activation, there's at least 8 people in the room who come to the patient's bedside before they arrive. So it's sometimes a crowded, sometimes a little chaotic, and depending on the patient's injuries, obviously, their life-threatening injuries and medical needs take priority. But that said, this is still an important opportunity to screen and identify patients. And so this group, led by Tanya ZAKRISON, used a multi-center study to identify the prevalence of IPSV in men and women who presented to trauma centers regardless of their mechanism of injury. So if they were in a car crash or something totally unrelated, they were still being screened for intimate partner violence. They looked at adult patients who met trauma triage criteria. So as I mentioned, patients who met that degree of injury, and they excluded patients who basically would not be able to consent to participate for any reason or needed an emergent procedure. Their screening process was done by a variety of different individuals depending on the center they were at, including social workers, behavioral psychologists, trauma nurses, and then even behavioral volunteers. They used 2 different screening tools. One is the HITS Intimate Partner Violence Screening Tool, which asks 4 simple questions. How often does your partner physically hurt you, insult you or talk down, threaten you with harm, or scream or curse at you? And then a sexual violence screening tool as well. And they screened over 2,000 patients over a 1-year period, and they found that the overall prevalence in patients who were admitted to the trauma centers was 11.4%, 16% of women and 9% of men, which is fairly high. And they found that the rates of identification really varied based on the resources of the hospital. Centers with dedicated behavioral psychologists or clinical social workers had the highest positive rates. But it really does underscore that this is a problem in our is present and prevalent in our trauma population, and there is a need for proper screening. These figures here just demonstrate that the difference across trauma centers. So Parkland is a major trauma center in Texas, Ryder is in Miami, Grady is in Atlanta, and Loma Linda in California. And you can see that Parkland has a very involved and robust violence intervention center, as does Ryder, and they have the greatest resources, and not surprisingly, they picked up the greatest number of cases. And we see some of those same patterns that we saw in the Joseph study I showed you earlier with high representation of minority communities. So this group concluded that the prevalence of IPSV is nearly 1 in 9 trauma patients at major trauma centers. And so just to give you context, at University of Utah, we admit we have somewhere between 21 and 2,500 trauma activations a year. So 1 in 9 of those patients would screen positive for intimate partner violence. And these patients also have a higher rate of trauma comorbidities, including substance abuse, mental illness, trauma recidivism, all of which apply to the patient that I showed you earlier. And therefore, universal screening of trauma patients is warranted. Screening only based on risk factors will underestimate the prevalence and not catch people who really could benefit from interventions and resources. And so screening, universal screening is really important. And then secondly to that, we need interventions that are effective for patients who do screen positive. Just screening is not going to improve patient outcomes at all. And I also just wanted to quickly highlight the risk of strangulation. This is very important because it carries a very high risk of death before, during, and then after the admission. There's a risk of concurrent brain injury or anoxic brain injury with oxygen being restricted to the brain, and then also a high risk of stroke with a carotid artery dissection, either at the time of injury or afterwards. So this injury and this injury pattern is high risk for the patient, and also represents a risk for their family members and even pets because of the degree of violence that is involved in strangulation attempts. And so but this does follow the patient through their life. And so recognizing the signs of strangulation is really important. And often there are no external signs of injury. And so it's very important to understand the more subtle presentations, including things like voice changes and swallowing difficulties, hearing changes or behavioral changes. And as clinicians, these are all things that we need to look for. At the University of Utah, one of the things we've done in the past, I think, couple of years now is we did implement universal screening for all our trauma activation patients. They're all seen by a social worker, and at some point during their admission, they are screened we use the HARC tool, so humiliation, afraid, rape, or kick, and then we've added screening for strangulation as well. So finally, moving to the left, even before patients arrive in the hospital, what can we do for people in the community? And this is where our trauma program is really leading the way here. And so I just wanted to highlight some of the work of Jamie Troyer, Emily Johnson, and Linda Sossenheimer, who are supported by a grant from the Utah Department of Health. And they've come up with an amazing curriculum on primary prevention of intimate partner violence. Over the course of the next few months, they're hosting 14 live virtual learning sessions, and then there'll be some hopefully in-person training sessions in 2021 if we get to that point. And there are 5 areas of focus, or the 4 areas of focus are on healthy relationships, social factors attributed to the prevention of intimate partner violence, the use of language and communication with patients and community members in preventing intimate partner violence, and then prevention resources that are available at the local, state, and national level. And here is their curriculum in terms of their topics. They have a broadcast date and then a rebroadcast later in the week. You may, if you're interested, may be able to use the QR code that I've put up here to register, or you can email Jamie Troyer. Their sessions are also all hosted on the University of Utah Office Network and Development Telehealth YouTube website. So you can watch them on YouTube as well. There's educational credit available for those who participate as well. So this is a really unique educational opportunity that I think is not really available anywhere else in this country. And so I'm excited to see how many people are engaged with this. They've right now been having a really good level of engagement with nurses, EMTs, physicians, and other community members. So this is really, really exciting work. So in summary, we know this intimate partner and sexual violence is common. Trauma admissions represent 1 point for screening and identification of patients. They need to be accompanied with effective and culturally appropriate screening practices, and then paired with effective resources and interventions in order for this to be effective, though. And then primary prevention and education initiatives really are essential for early identification and intervention. And so I think our trauma program represents one area where we can directly interact with patients early, as well as doing outreach into the community. In terms of people, tried to acknowledge people along the way here. We do have, like I've mentioned, we have a really great trauma program led by Janet Cortez, Jamie Troyer, Emily Johnson, and Linda Sossenheimer. Kathy Franchek is a pediatrician who has been leading a lot of the clinical intimate partner violence initiatives, including patient screening. And then our University of Utah Health social work team is really key to this whole endeavor. And so I'd like to acknowledge their involvement too. Thanks. I'm going to stop there, and then Dr. Anzai, you can.
Yes, thank you so much, Marta. That was really, really wonderful. The very comprehensive. You can see that two speakers really touched the different spectrum of gender-based violences. Certainly from the community work to identifying a research epidemiology to background of how defining a gender-based violences to really the completely clinical end of the Dr. McCrum that actually when the patient arrived in the hospital, how do we manage? And also that portion might be maybe a small portion of it, and maybe just we'll be looking at the tip of the iceberg, just like a two speaker mentioned. So please write the question in the chat boxes if you have any question. Let me ask a question to Dr. McCrum first. I know this is required a really broad range of people to address the gender-based violences. But most of the time people call 911 or ambulances if something happened and you're hurt at home. I believe EMT play very significant role because you are face-to-face with victim. They may not want to go to hospital. They may not always transfer to the hospital. So before get to the hospital, the emergency medical technologist will have a conversation with victim. What's the role of EMT?
I think you bring up a really important point that our first responders played a really important role in identifying survivors or patients, people who are experiencing violence in their home or in their environment. There are different screening tools, and I do get some training in this, but there are different screening tools to try and identify the highest risk. And so there is a program called the Lethality Assessment Program, which is something that we are trying to help with greater education for our first responders, where I believe it's an 11-point questionnaire that can be quickly done with potential patients, and the idea is to identify these very high-risk patients, because you're right, they may not want to go to the hospital, so they may not even reach the hospital doors, or they may not be injured enough. This program has been implemented in Baltimore and I think other areas in the country where a positive screen, they have the ability to connect victims on the spot with resources. So with the Utah Domestic Violence Coalition, for example, or if they are in need of shelter or different different identified needs. And so I think extending these resources and training beyond the walls of the hospital is really important. And I think first responders do play a really important role.
Mm-hmm.
I want to add to that. Oh, go ahead.
No, go ahead.
Annie.
I was just going to say, thank you for bringing up Dr. McCrum, the LAP, and all that wonderful work. There's also a non-fatal strangulation committee that formed specifically to respond to how can we get more people to immediately see a healthcare provider because of, as you so eloquently highlighted, the fatal possibilities of unaddressed strangulation. And so there is a non-fatal strangulation committee, and they have a protocol as well to get person seen by a sane nurse, or at least talking to a sane nurse sooner than later, because oftentimes a lot of folks may not remember that they were strangled, or even you would have to have a witness actually see that happen because they literally blacked out. And so if there's any indicators, I know that also dispatch has been trained on the non-fatal strangulation protocol to also get them to get connected to a nurse sooner than later.
Yes, and I have to say that what really made me very excited, first of all, with Annie's talk that started talking about it as a public health issue, a public health epidemic. I'm a maxillofacial surgeon, Dr. McCrum, so I've developed protocols too that use head, neck, and facial injury with the partner violence screen. And you're very, very right about screening. It's not what you're asking, it's how you're asking. I found the data to be interesting that you showed of the trauma centers because there was no data on facial injuries. And, you know, the facial injuries happen, as you know, 75% of the time. So there's something that, you know, we really do need to look at. And I think the part of the beauty of Annie's idea and, you know, all of our involvement is to have an interprofessional collaborative to really come up with a wonderful screening tool that takes everything into consideration. And, you know, trauma is where all the answers can be, but it's not trauma that's obvious. And I'm sure that, you know, part of what you discussed was a trauma-informed care team that your colleagues are working on. So it's very exciting. So I think both of you as speakers kind of put it together in terms of a collaborative that can be developed with that. There was one question first that came up in the chat box about wanting the link, Dr. McCrum, for that group that you were talking about. That was from Kimberly Kotcherhans and all panelists. So I see that you did do that.
Yeah, and I will also add Jamie Troyer's email address, and you can contact her directly and she can help you with registration.
Great.
You might want to repaste it because I think it only went to panelists, not to participants. So it needs to be panel. You need to select panelists and attendees. Yeah.
Oh, thanks. I will do that.
I made the same mistake earlier, so no one was following along.
Yeah, and she followed up with another comment, if I can read it. With IPV, that next phase from hospital to home or other is critical to impacting whether people are able to respond to first responders, questionnaires, screening, etc., especially for chronic abuse. The return home is often worse than the initial reason they went to the hospital. Are those resources becoming more refined and accessible, Dr. McCrum? I didn't know there was a difference. Maybe you can deal with that question.
Sorry, I'm just rereading the question. Critical to impacting whether people respond.
And she just said the difference was regarding who I was addressing.
I think this is an area that right now the approach is usually the best we can with the social work resources and the resources we have available in the hospital. But I think most clinicians have an underlying level of concern that probably it's not enough. And so I think that this is a really good point, and that accessing resources may need to be, or having availability of resources presented to patients may need to be not just within the hospital environment, but also after they leave. The patient, for example, that I mentioned in my presentation was discharged to her parents' home, but that may not be where she stays. And so I think, you know, the idea of, finding a safe discharge location for the patient is obviously, of primary importance, but that may not be where the patient ends up staying long-term, and, where they end up going from there. And so I think one of the things that probably needs to be done is having a better continuity of resources available to patients, so that whether they're returning home or going elsewhere, it can be a safe location. As clinicians, we only see a small part, but I think that's something that probably partnerships between the hospital and out-of-hospital community would really be helpful there.
Yeah, I was going to say that. I think that that's where I think a lot of the post medical treatment. People are going to get a lot of their support from service providers if they're connected. But then the challenge, and we see this across the country, is that there are service providers ready at the get-go to support survivors of violence, but it may take survivors multiple attempts before they're ready to actually get the support that they need. And many survivors may continue to live in the abusive conditions, even as they're seeking out services and resources. I think that one of the challenges is that there is linguistic limitations to our services in Utah. And so a lot of the services are in English. And so then if you have communities that speak other languages, or communities that may have a range of cultural and whatever backgrounds, that may also be barriers, because that may be part of the challenge in why they don't come forward, because of their cultural barriers around stigma. And that was something that we found that a lot of survivors of trafficking in Utah were speaking to, is how they continue to experience stigma at a range of service points, from medical services to even accessing social services. And so there's a range of barriers that we need to address when it comes to supporting survivors in the long-term haul. So you're right, Kimberly.
So the other things, Annie, perhaps one of the tricky situation might be the woman who have a children with abuser. In that situation, I think it would be really difficult for women to leave their home, despite the challenges that she or he experienced with, and unless the financial support they receive to be able to separate from the potential perpetrator or abuser, I think it's a real challenging situation for women to get away from the condition. So what are the things that we as a community can provide for those situations?
Yeah, so I've been doing research on housing access for survivors of violence for the past 3 years now. I've been tracking organizations, following organizations in South Dakota, New Orleans, as well as in California, and then in Utah, hearing about the need. And I think that what we can say is that housing is a number one and central need. And if people don't have safe, secure housing, they will not leave their abusive conditions, because if that is the only place that they can reside and support their children, and then they will even stay within abusive conditions. So housing, even in a state like Utah, where housing first programs, we are propelling survivors into having their housing needs met more immediately than other states. It's still an ongoing battle. And I think part of the challenge is that what people really want is not just emergency, they need long-term housing. They need a safe home, a place they call a home, not a place that they're just going to one-stop reside in and then have to move again with all their kids to the next point. So housing is a huge one that I think that we can address. The Fight Against Domestic Violence organization that we've been working with does work with resourcing and trying to get people into secure housing. And so that is the executive director is Brooke Muir. And so they've been trying to work on those kinds of resourcing, but it's ongoing. And so housing, and especially in a time of pandemic where we're seeing that people are losing their jobs and are experiencing more insecurities. And so as those insecurities pile on, you may continue to even more so stay. And so what we saw with our COVID study is that there was an increase in reportings up until July, and then a drop off. And so part of the question becomes, why was there a drop off in reportings to law enforcement and people seeking out, these kind of legal options? And part of it might be, which it's just a suspicion, so we will have to continue to investigate, is that they may be not reporting as much because they're staying, right? They're having to stay in their conditions and just kind of wait out this current climate.
I think unemployment severely affecting more women, particularly for women of color, due to COVID-19 pandemics and also economic impact. And if you don't have a financial resources to live yourself, it's very difficult. So it's kind of a little bit of vicious cycle right now. Dr. Halpern?
Yeah, I just wanted to say that it is a vicious cycle, and that's a wonderful segue, because I'd like to now ask Dr. McCrum, since, as another trauma person, a lot of the research that I found is that, the victims of violence have a decreased lifespan because there are these 10 common chronic illnesses associated. And I'm kind of curious whether you've looked at that data in your questionnaires. A lot of the research that I've done with Grady Hospital, interestingly enough, we did a multi-center study too, looking at facial injuries and other injuries. Do you think we can catch more when you happen to see a common thread with chronic illnesses because of what they're associated either with present or past trauma, if we can capture more that way?
Yeah, I think that's a great question. I think until just about a year ago, our data on long-term outcomes and trauma was very, very lacking. And there's starting to be a greater focus on long-term outcomes in trauma, both mental health and physical health. And so I think there is not good data available to this point, but I think that because this is an area of increased attention and research, it is particularly the intersection between physical health and mental health, that I think this is something that is definitely right for investigation moving forward. I think as clinicians, we often focus on, the 38-day outcomes and the things that sort of get evaluated as quality metrics, but we need to go beyond that. And so I think this is definitely one area where long-term outcomes will be really important, as well as, working with colleagues in other, social sciences and other areas to really capture the full impact of intimate partner relationship-based violence, gender-based violence on people's lives.
The health costs, and I know that you've mentioned this, Annie, are in the billions of dollars because of the health issues. And the beauty of your gender-based violence consortium, maybe you can hypothesize when you talk about the visual mapping with some of the things that Dr. McCrum just said, with how we want to look at the data. Maybe you can give us an idea.
About I'm happy to talk about the visualizing gender-based violence. So right now what we are working on is creating an interactive platform where people can actually think about a range of research that is ongoing, but we're looking particularly from 1994 to the present. And so we won't be going back, even though we know that the movement really was, invigorated in the 70s and even in the 60s. And so we're not capturing a pre-VAWA moment. We're capturing a VAWA was passed, and what does the research look like moving forward from there. And so we'll be looking at that, as well as looking at a history of policies, which there's a lot of laws in the language, the ways that it refers to communities. And actually, when we think about our laws, they impact how legislature makes decisions about where resources go. And so we'll be including that in the data, as well as looking at a history of services. That's going to be a little bit more trickier, because if organizations disappeared, we will have to rely on folks who can tell us that they existed and then disappeared. And so if folks are interested in sharing with us this sort of historical knowledge, I look forward to hearing from you, because that's that. And eventually we want to incorporate into that a history of injury. And that's been some of the conversations that we've been having as leadership of the consortium, is thinking about what that might mean to look at a history of injury. And so whether we're thinking about it to its most severest, which mortality, which Sonia Solari works on, to the range of kinds of abuses that survivors experience, from psychological, emotional abuse, economic, to then eventually, physical, which is where you're all seeing it in the healthcare, as you're seeing the culmination of it.
Mm-hmm. I want to lastly ask Annie a question. Now, it feels like we have so much to do in this space. I know the October is Domestic Violence Month, and we all talk about it, but I don't want just talk about it. So in a way that there's so much to do. And then I know that we are creating a multidisciplinary consortium, but we still need a lot of resources and funding. So how do we advocate this type of work to either state or county or even federal or national level? How do we get the resources that we need to make an impact? If you could elaborate, that would be great.
Well, that's a huge, the money question is a huge one, because don't we all need it? And then what we're seeing in pandemic is the wallets are definitely tightening, right? And so I think that one of the things that we don't want to see is, as the wallets tighten, is that our VAWA resources and TVPA and the other range of gender-based violence resources also don't get tightened and disappear. And so oftentimes you'll see organizations do call for, when there's reauthorizations, for appeals to protect that. So what we do need to do is definitely protect the very resources that are in place. What we're seeing is that a lot of the organizations don't have prevention resources. And so that's drying up, because it's all going directly to services right now. And so when there isn't enough pool of money, they kind of, it goes to the crisis, right? Things when people are in crisis. And so we're seeing that, I think, in a range of other contexts as well. And so then I think people is our biggest free resources, the people power. And so in the meantime, as we don't have financial resources, or as we're looking at collaborations to apply for grants, to do research projects, to do services, people in community doing services. I don't do services, that's all the community, and at the medical. And so as you're all working at finding those resources, and I think that one of the things is that at South Valley Services and YWCA is going to be advocating for, how do we then create a statewide campaign to actually encourage more awareness in our communities. And so there's a range of things going on, but the money one is a big question. And I think as we look at our economy, that's also going to be the biggest dictator of where resources go. And so as money disappears, we have to get more creative.
Mm-hmm.
A comment just came in. Are you tracking suicide and self-harm with relation to IPV, or is it that off track for this discussion? I know there are very traumatic injuries that come from that symptom in addition to direct harm from IPV. If we can answer that, and then there's another comment. So,
Marta, would you like to take this question about tracking suicide or self-harm related to IPV?
I think it's a really good point. And I can't say that I've either seen any studies that have specifically addressed this, or that we're specifically tracking it. But I think it's definitely something worth looking into, and that we might be able to get some of that from our registry. One of the problems with this, especially self-harm, is that it somewhat needs to be self-reported. And so when we're looking at some of the large databases in trauma, or even some of our individual, single center studies, if patients don't report it, which they may not, it can't be captured. And so this would have to be something that is addressed in a very sensitive way, with trained personnel, and probably a prospective manner, because it is just not going to be accurately represented in our data sets.
Yeah, you're absolutely correct. When we look back in the data about attempted suicides as an escape from an abusive relationship, in 2002, Jackie Campbell, I think you mentioned this, Annie, in one of your references, did a very interesting study looking at health consequences, again, in victims with domestic violence. That was a 2002 Lancet article, a long time ago. And the data now is coming out more, but it is coming out as anecdotal with a lot of PTSD data, for instance. It's there, but you have to tease it out. And I think we're starting to look at that more now. But I think you're right, Dr. McCrum, it's very difficult. It is very difficult because it's shaded by other things.
So I think that this is great. I think that Tara Whiting wanted to get a copy. I think this was recorded and available on the Facebook. So if you missed a portion of it, or just have to leave earlier, the entire discussion and the presentation will be available for all of you. And I just wanted to thank you, both Dr. Annie Fukushima and Dr. Marta McCrum, for just fantastic, very broad perspective of gender-based violences. We all work together to find a solution and at least mitigate some negative impact of gender-based violence and intimate partner violences. Thank you so much. We hope you stay well and safe. I know that COVID-19 is still out there, so be safe and well. Thank you so much.